Okay, so these are our references, mainly WHO guidelines. So we'll be talking about basics, a short overview about the coronavirus, infection prevention and control policies we should put in place, engineering and environmental controls, IPC in the pre-hospital setting, so for the EMTs out there, decontamination, as well as mainly doffing the PPE. Okay, so coronaviruses are a large family of viruses, 7 of which affect humans. 4 are not specially named because they cause the common cough and colds. 2 is more common, SARS and MERS. And the most recent one, the novel coronavirus, which is recently named SARS-CoV-2. So when we talk about the virus itself, we refer to it as SARS-CoV-2, while we call the disease as coronavirus disease 2019. So the symptomatology is fairly common, such as fever, cough, other respiratory symptoms. Some will have difficulty of breathing. So we can't really differentiate COVID-19 from other coronaviruses or from, in fact, other causes of influenza-like illness. It's mainly initially known or presumed to be animal to human transmission, a zoonotic spillover event, but we have seen that it is able to propagate very efficiently from human to human. There is limited data to support asymptomatic transmission. Yes, there are case reports, which show that it is possible to transmit from an asymptomatic host. However, based on epidemiologic data, it is not a significant driver of the epidemic, which means that most people who get infected are still due to someone who is symptomatic. Because if we look at the disease, it is a respiratory virus, so it's pretty hard to transmit it if the person isn't coughing or sneezing. We have what we call the R naught, or the basic reproductive number, which is around 3. That means that for every one COVID confirmed case, they can infect on the average around 3 other patients. Now, this is if there are no prevention and control measures in place, such as if there is no community quarantine, if we don't do contact tracing, or no screening at ports of entry. But if we do have these prevention control measures, then that can bring the basic reproductive number to a lower value, hopefully less than 1. So if we compare this basic reproductive number for polio, which we recently have an outbreak, the basic reproductive number is 7. So for every 1 polio case, they can infect 7 other cases. For measles, the basic reproductive number is 18. So for every 1 measles case, they can infect 18 other kids. So for COVID-19, it's fairly lower at 3, but it's still worrisome because there is still a possibility of exponential increase as we see in other countries today. So it's mainly transmitted through droplet, contact, or fomite transmission. Yes, it can be airborne for specific aerosol generating procedures, such as endotracheal intubation, tracheostomy, invasive ventilation. So usually this happens in a healthcare setting. In community settings, it's really mainly transmitted through droplet. So there is no data to show that in community settings, it is transmitted by the airborne route. Therefore, the WHO recommendation stands. There is no evidence that surgical masks are useful to protect non-sick persons. So who is advised to wear a mask? For surgical masks, it's advised for persons caring for the sick, persons with respiratory symptoms, and health and other frontline workers. Those who need to wear the N95 respirator are health workers attending to patients under investigation, and those handling clinical specimens or soil supplies of these patients. So when we say patient under investigation, that means any person who, number one, has the symptoms, and number two, has history, travel history to areas with local transmission, or exposure to a confirmed case in the past 14 days. When we say a person under monitoring, it's any person who has no symptoms but has the travel or exposure history. So the areas with local transmission get updated every day. I suggest you check the WHO website frequently to get the latest update on which countries have local transmission already. So COVID-19 is diagnosed mainly through RT-PCR or reverse transcriptase polymerase chain reaction. It's a difficult test to perform, which requires specialized equipment, highly trained laboratory scientists, and a BSL-2 laboratory. So this is the reason why we can't easily set up a facility here in our region because, number one, we need the equipment. Even if we do have the equipment, we still need a specialized BSL-2 lab that is dedicated for highly infectious viral pathogens. The kits that we mentioned are composed of reagents, enzymes, and other supplies. So it's not a simple bedside or rapid diagnostic test, such as a pregnancy test or a dengue NS1. There is currently no FDA-approved rapid diagnostic test, so please report to DOH or FDA if you encounter businessmen who try to sell you a rapid diagnostic test. Now, RITM is the National Reference Laboratory for Emerging Infectious Diseases. We used to send all our specimens to RITM, but since Monday, SPMC, which is the subnational laboratory for Mindanao, is already accepting specimens. So we expect a faster turnaround time starting this week. Now moving to infection prevention and control policies, again, I repeat, COVID-19 is spread by droplet, contact, and fomite. It can be temporarily airborne only for specific AGPs or aerosol generating procedures. So wearing the maximum PPE all the time is not always required if it's not indicated by mode of transmission and exposure. Number one, because wearing full PPE all the time makes it difficult to perform patient care, brings discomfort for health workers, thereby leading to a possible breach in protocol, and the higher cost, which leads to lower sustainability. It's useless to have the most cutting-edge PPE, a PAPR, for example, if you can only use it for a couple of days and you have no PPE left for the remainder of the time of the epidemic. So PPEs for COVID is different from the PPE for Ebola. COVID is transmitted by droplets, whereas Ebola is transmitted through body fluids. And therefore, coveralls, for example, are not necessary for COVID. So why do we see in the news and social media healthcare workers wearing coveralls? That's because at the start of this epidemic, most of the PPEs that were readily available were stockpiles in preparation for Ebola because that was the most recent epidemic last year. So we had to use what was available, and so we were able to use those things. However, it's not really designed for COVID. We can use other forms of PPE for COVID, which I will discuss later. So once PPE is worn, we should minimize unnecessary contact with the patient and the surroundings. And who will provide the PPE? So for local health personnel, those under the local government, the provincial or municipal governments, such as the provincial hospitals or RHUs, it is the LGU based on the DILG Memorandum Circular 2020-023 who should provide their health workers with PPE. So for PUI or confirmed case, what type of PPE should we wear? What is recommended by WHO for SARI or severe acute respiratory infections are the goggles, face mask, or N95, isolation gown, clean gloves, and surgical mask for general patient care, or N95 for generating procedures. So I ask other participants to please turn off your microphones. All right. So because we have a limited supply of PPEs, we have to be careful and we have to rationalize our use of these PPEs. We should ensure tasks are carried out by as few staff as possible without affecting quality of care. Ensure that tasks are grouped together. So if you have to do a lot of things for the patient, you have to start an IV, get a history, get blood samples, do a nasopharyngeal swab, do them in one setting so that we don't waste the PPE going back and forth in and out of the room. Next is we should have a means of communication between the patient and the staff without direct contact. So either have an intercom in the room or give the patient the nurse station cell phone number so that if there are basic concerns that can be arranged or resolved through the phone call, then you don't have to go inside the room and use PPE. So the usage of these personal protective equipment will depend on the type of exposure. So for example, if we are providing direct care to COVID-19 patients, it's actually enough to wear the medical mask, gown, gloves, and eye protection. If we are doing aerosol generating procedures such as endotracheal intubation, that's the time where we use the N95 mask. For visitors who enter the room of the patient, they can wear a medical mask, gown, and gloves. They don't need to wear N95, they don't need to wear goggles. So this table can be downloaded from the event materials that you could access using the event password. And so on. So for example, if you are in triage and you are handling patients without respiratory symptoms, you don't really need to wear any PPE. If you're a staff, for example, working in another part of the hospital, and there are times that patients will have to pass along your area, if you're not really involved in direct contact with that patient, there is no need for you to wear PPE. So please do download the WHO guidelines for rational use of PPE so that you can see this complete table there. So how else do we minimize the need for PPE? Number one, telemedicine. So some organizations now and some hospitals, in fact, have started to publish a telemedicine hotline. So if there are basic concerns, of patients, they don't have to go to the ER or the OPD. They could just call, and a physician would be able to answer their concerns without having to see the patient directly. So that minimizes exposure for the healthcare worker, and that minimizes exposure of the patient. Physical barriers to reduce exposure are useful. For example, glass or plastic windows in triage. We've seen some innovations such as the aerosol box for endotracheal intubation. So that's also good. Ideally, visitors will not be allowed for PUIs and COVID confirmed cases. If necessary to have a visitor or a watcher, then they should wear appropriate PPE, and the donning and doffing should be supervised each time a visitor enters or exits the room. They should not be allowed to put on or take off PPE without any supervision. So facilities should have a written policy for infection prevention and control. Those who may need to wear N95 should be fit tested. Okay, and when going to the hospital, wearing scrub suits should be the norm. So when you leave the hospital, you should not be wearing the uniform that you have worn within the hospital. Staff should change into street clothes prior to leaving the hospital. And white coats, especially long sleeve ones and other kinds of coats, should not be worn in the facility because, let's face it, when was the last time that you washed your white coat, right? So those act as fomites. So health workers should also have records, okay, of who comes in contact with PUI or confirmed cases, and there should be an active influenza-like illness surveillance. So those taking care of PUIs and confirmed cases should have a daily temperature and symptoms check, and they must immediately inform the Infection Prevention and Control Committee if they experience influenza-like illness. Dedicated equipment is ideal, all right? If equipment needs to be shared among patients, clean and disinfect it between each patient use. Hospital should have a flu fast lane. Okay, this is a special triage area outside the main ER. Okay, so it should be staffed at all times so that no possible PUI will be kept waiting there. And all persons coming into the facility before they even get to the ER or OPD should be screened for travel and contact history. As much as possible, patients should be placed in single ventilated rooms with their own restroom and anteroom. Air conditioning may be used, but windows must be kept open or exhaust fans turned on to facilitate air exchange. So I repeat, even if you have air conditioning in the room, windows should be kept open and exhaust fan turned on. Close the main door, but the windows facing outside should be kept open to facilitate good air exchange. By the way, there's a Q&A section on the app. So if you have questions along the way, you can type your question there in the Q&A, and we'll address all of that at the end of the discussion, at the end of the lecture. So if cohorting is unavailable, we have to place patients in the same category in the same rooms. So there should be a different room for PUIs, unconfirmed cases, and a different ward for confirmed cases. Patient beds should be at least 1 meter apart, and non-critical equipment must be decontaminated between patients. When we are visiting multiple patients in a ward, then staff should wear a single set of PPE for the entire duration of the activity to save up or to rationalize the use of PPE. Masks should not be removed between patients, and the user, the healthcare worker, should not touch the mask during the activity. Let's not forget the 5 moments of hand hygiene. So alcohol-based sanitizer or a lavatory with soap and water should be available outside each single room or within the ward, so healthcare workers can perform hand hygiene anytime. So in the pre-hospital setting, we also have some guidelines. If we are transporting non-critical ambulatory patients, then we should transport them with the minimum required staff. For example, just the driver and one nurse or EMT. We should ensure that transport vehicles have as high volume of air exchange as possible by opening the windows. So when we transport PUIs, windows should be kept open in the ambulance. Do we need a special ambulance for transporting PUIs and confirmed cases? The answer is no. Any ambulance, any PTV or patient transport vehicle may be used to transport PUIs or confirmed cases for as long as the staff inside are wearing proper PPE. So you don't need a special ambulance or PTV. For DRRMs, when responding to general calls, the operator should screen patients who present with severe acute respiratory symptoms if they have the travel or exposure history. We should avoid aerosol generating procedures such as suctioning, intubation, unless required for life support. Now, coordination is very important. We have a regional emergency operations center with a hotline for each province. So you have to inform the EOC and the receiving facility if you are transferring a patient. So please do not transfer patients without notifying both the EOC and the receiving facility. Ambulances or PTVs must be cleaned and disinfected while the crew is still wearing PPE. Don't forget to clean and disinfect equipment and high-touch areas such as door handles, the ambulance stretcher or cot, tabletops, and so on. Now, when we say decontamination, that means we remove soil and pathogenic microorganisms from objects. So there are three subcomponents of decontamination: cleaning, disinfecting, and sterilization. So cleaning is the first step required to physically remove contamination by foreign material such as dust and other organic material, blood, secretions, etc. Disinfecting is a process to reduce the number of viable microorganisms, and sterilization is a process that renders objects free from organisms, including viruses and spores. So before we proceed to disinfection and sterilization, objects must first be cleaned. All organic materials such as blood and secretions and other dirt should be cleaned before moving to the disinfection step. We should be cognizant of high-touch surfaces such as doorknobs, our stethoscope, multi-use medication vials, our cellular phones, the equipment around the patient. These things get touched all the time, so we need to keep cleaning this. No? So when was the last time you cleaned your phone, you alcoholized your phone or your stethoscope? So we have to frequently clean these high-touch surfaces because they can act as fomites. So when cleaning rooms, we have to avoid possible generation of aerosols. So rather than dry dusting or sweeping, we should use a damp cleaning techniques with a moistened cloth or a wet mop. When disinfection is required, ensure that cleaning is done. So remove all the blood, all the other organic material before disinfecting the surface. Mop heads should be cleaned daily. Don't spray or fog occupied or unoccupied rooms with disinfectant. So it's a dangerous practice. It can cause respiratory distress and has no proven disease control benefit. So the best way to clean the room is not by fogging or misting, but still by wiping down all the surfaces and mopping the floor. If we need to accommodate patients, try to use rooms with no carpet. If you do need to vacuum, make sure that the vacuum has a HEPA filter. For those in working in a support staff, you should be wearing gloves if you're washing items by hand. Okay, wash the dishes and eating utensils after each meal or use. If we're cleaning up patient laundry, we have to remove solid material first. So if there's feces on the bed sheet, for example, we have to remove that, dispose it in the toilet before placing the linen on the laundry bag. So we should avoid sorting linen in patient care areas, and we should place the linen with minimal manipulation or agitation. So don't try um, to take out the dust, for example. Just put it all in the bag and sort it out later. So we have two common disinfection chemicals that we can easily use. Number one is alcohol. So ethyl alcohol, at least 70%, generally superior to isopropyl alcohol, but we can still use isopropyl if there is no other option. So we can use it to disinfect small surfaces. Bleach or sodium hypochlorite or chlorine is a strong and effective disinfectant. However, we have to be sure of the way we dilute bleach, because if we dilute it too much, we may reduce its effectiveness. So when preparing bleach, we should remember to mix chlorine or hypochlorite with cold water, because hot water decomposes the bleach. Surfaces again must be cleaned of organic materials before disinfection. So you have to remove mucus, vomit, feces before doing the disinfection step. Most household bleach solutions contain around 5% sodium hypochlorite, depending on the brand. So you have to be sure of the starting solution, whether it's 5% or 2%, or sometimes they display it as parts per million of available chlorine prior to dilution. Because like I said, if we dilute it too much, we will reduce the effectiveness. So the recommended dilution is 1 to 100 for a 5% sodium hypochlorite. So that means 1 part bleach is diluted to 99 parts of cold water. If you have a liter of water, for example, you mix 10 ml of 5% bleach, and that will give you a 1 to 100 dilution. Some studies recommend a higher dilution of 1:50. So for 1 liter of water, you can add 20 ml of 5% sodium hypochlorite instead. So adjust the ratio of bleach to water as needed to achieve the appropriate concentration. So if you have a weaker preparation of bleach, for example, 2.5% is your starting solution, then you have to add twice as much bleach. So 2 parts of bleach to 98 parts of water. So bleach doesn't disinfect instantly. For non-porous surfaces, it needs a contact time of at least 10 minutes. So for example, if we wipe down the table or if we mop the floor, we should not wipe it dry immediately after. We should allow the bleach to stay on the surface for at least 10 minutes to adequately disinfect. If we are dealing with porous surfaces such as clothing, linen, for example, you have to immerse those things, and a contact time of 30 minutes is recommended for linen and other porous substances that need to be soaked. So bleach decomposes with time. You have to prepare a fresh diluted solution daily. After 24 hours, you have to discard it and make a new one for the next day. Bleach should be stored in a cool, dark place because it decomposes under heat and light. For high-level disinfection, there are some other chemical germicides. We can still use bleach, but at a higher dilution, 1,000 parts per million or 1:50 dilution. You can use pasteurization or autoclaving. For mech vents specifically, you have to wipe down the controls and outside of the equipment, disinfect the tubing and the interior lumen with high-level disinfection. So use 1:50 dilution for bleach. So for pressure lines, it's not necessary to clean between patients because those are not exposed to the patient. And another special note, if we are handling cargo from affected areas, to date, there is no data to suggest that contact with goods or products from countries affected by COVID-19 have been the source of disease in humans. So although theoretically COVID can be transmitted through fomites, we don't have any documented data to show that products which have been shipped from China, for example, have been shown to cause or to transmit or carry the disease. So last topic here, specifically about doffing PPE. So as healthcare workers, especially for the doctors and the nurses, if we recall our time at the operating room, we were very careful in gowning and gloving prior to surgery, but we were not careful anymore when we take off the gown and the gloves after surgery. So for when taking care of infectious patients, it should be the other way around. You can don your PPE any way you like, but you have to be very, very careful when taking off the PPE because that's the most dangerous part of your entire patient encounter. So if you're wearing the PPE and facing the patient, you know you're protected because you're wearing the PPE. The risky part is taking off that PPE. So you have to be very careful and you have to have a trained observer, a partner who is looking at you, checking if you're touching the right surface or touching a contaminated surface. So I'm going to show a short video on doffing the PPE and I'll walk you through it as we play the video. Okay, so you can see here that the PPE being worn is the PPE recommended for COVID-19. Again, I repeat, you don't need coveralls, you don't need a head bonnet and shoe covers for COVID-19 because it's not transmitted by all body fluids, but it can only be transmitted through droplet or contact or fomite. So you just need a face shield, your mask, gloves, and the disposable gown. So when you reach the doorway or the enter room, the first thing that you take off are your gloves. Okay, be sure to perform hand hygiene before taking off the gloves. And after taking it off, you have to do hand hygiene again. So for each piece of PPE that you take off, you have to perform hand hygiene in between. So you're going to be using alcohol a lot or washing your hands for every step, for every PPE that you remove. So after performing hand hygiene, you remove your face shield or goggles. Be sure when you take off the face shield to only touch the side. Okay, don't touch the front of the face shield because that will be contaminated. Just touch the side or the strap. All right. After removing the face shield, it should be thrown away, single use only. The next thing that you remove is your gown. Okay, so you tear it off, rolling it inside out. Okay, and be sure to discard it properly and to do hand hygiene again after taking off the gown. And once you close the patient door, that's the time you take off your mask. Okay, be sure to touch only the straps, not the front of the mask, which may be contaminated. Okay, take off the lower strap first before the upper strap and discard it immediately in the trash bin. Do hand hygiene after the procedure. All right, so that ends our discussion. Now we're going to entertain some of the questions. Okay, we have a question here from saying, what if infected persons are not using the mask? For me, that's always on my mind when I go out. That's why I still use mask whenever I go out. Okay. So that's why we have what we call the social distancing. Let us recall that for droplet, it can only be transmitted within 1 to 2 meters. So even if we're not wearing a mask, if we maintain the 1 to 2 meters distance, then the droplet will not reach us. So in fact, when you're in the hospital, if you're just standing outside the patient's room, then you don't even need to wear a mask because the droplet cannot reach beyond 2 meters. However, if you do go into very crowded places with, where you cannot achieve the proper distance, then that is advised that you should wear a mask. That's why one of our advice is to maintain the social distance and avoid large crowds. We have another question here, fomite viability for COVID-19. Okay, so there are studies that show that coronaviruses, including SARS, the original SARS, can persist on surfaces up to 9 days, which means that we really have to clean surfaces all the time because we can't rely on the heat or on sunlight to disinfect the surface. Another question here, during training, we were taught to wear double gloves. Yes, you can wear double gloves, but it's not necessary. You can wear single gloves as well because we are not performing, it's not a bloodborne pathogen, actually. So you can choose to wear single glove if we have limited supply. Another question here, should there be a difference in the use of PPE for those undergoing surgery and for PUI or confirmed case? Okay, so for surgeries, if the patient is a PUM, which means the person has the travel history or the contact history, but does not have symptoms, then there should be no difference with a regular surgical gown and mask and gloves. However, if the patient is a PUI, which means they have respiratory symptoms such as cough and fever, or they are a confirmed COVID case, then we should be wearing disposable PPE, including the gown, face shield, mask. As for the mask, if we are doing aerosol generating procedures during the surgery, such as endotracheal intubation, then we should be wearing N95 masks, which is why the recommendation for surgeries to PUIs or COVID cases is to use regional anesthesia as much as possible rather than general anesthesia. What could be the best thing to do during venipuncture of a patient who might be COVID-19 positive? So by this, we could refer to PUMs or PUI. So if it's a PUM and we need to do venipuncture, then um, there, there should be no difference in our technique because they are asymptomatic as a PUM. If they are a PUI, which means they present with respiratory symptoms, then we should also be wearing a mask. And the patient should also be wearing their own mask. As to what type of mask, surgical masks are enough because venipuncture is not an aerosol generating procedure. Another question here on recycling N95s. The recycling of N95 will depend on the pathogen and the mode of transmission. So for example, for tuberculosis, which is transmitted purely through an airborne route, tuberculosis TB is not transmitted through droplet or fomite. So WHO does recommend reusing the N95 for TB patients because it's purely airborne. But for droplet and contact pathogens such as COVID, then N95 should be single use only. All right, that's the end of the questions. If there are no more questions, thank you very much for attending this webinar. It's been a pleasure. You can download the references and this presentation through our bit.ly link. I'll also be uploading a recorded version of this presentation after we end the session. So thank you very much on behalf of the Department of Health. Thank you and good evening.